So our next panel is going to focus on local research that's being done here in San Diego, but also work that's getting done in TJ. And some of this work going to be about understanding social and behavioral risks, but also mathematical modeling of infections. We'll start with Dr. Laramie Smith. She is an assistant professor in the Division of Global Public Health, Department of Medicine. She's trained in social psychology as a behavioral interventionist, and her research focuses on supporting the prevention and treatment needs of HIV-affected and medically underserved populations. We're going to have speakers speak for 10 minutes so that we can have 5 minutes for questions.
So I'd like to first start by thanking and acknowledging that there's so much expertise in the room, specifically on the HIV epidemic in Tijuana, and that I've been able to leverage from that work for today's presentations. And in particular, start by thanking my colleagues, Drs. Goodman, Patterson, and Strathy, for allowing me to review the available HIV treatment data obtained from their community-based studies in Tijuana. My goals with these analyses are to explore the feasibility of the UNAIDS' latest HIV treatment as prevention response 90-90-90 in this context. So aiming for 0 new infections, the UNAIDS outlined an aggressive HIV treatment as prevention response targeting community-level viral load. The 2014 90-90-90 goal calls for 90% of all people living with HIV to know their status, 90% of those who are diagnosed to be on treatment, and 90% of those on treatment to be virally suppressed by 2020. The end result, where implemented, would achieve 73% community-level viral suppression. And to enhance the critical momentum and really leverage the substantial resources that would be needed in order to put this goal into action, the International AIDS Society has since issued the Vancouver Consensus, directly calling on individual cities and national leaders to take ownership over achieving 73% viral suppression by amplifying their current test and treat efforts. But what is the feasibility of achieving such an aggressive target in concentrated epidemics among men who have sex with men, individuals who engage in injection drug use, and females engaged in sex work, particularly in resource-limited settings, such as Tijuana? And how much might we need to actually amplify current efforts for such stigmatized, medically vulnerable populations who we know already face substantial challenges engaging in care? Considering what 90-90-90 might look like in this context, we know that it should, at least in theory, benefit from Mexico's universal treatment policies implemented in 2003, providing free clinical care and ARVs to those living with HIV. In Tijuana, accessing free HIV care through the government-funded Capacites Clinic can be challenging. This high-burden clinic serves approximately 1,000 patients and is staffed by 3 primary care physicians. It's located approximately 25 kilometers, or a 30-minute drive for those with transportation, from Tijuana's HIV epicenter in the Zona Norte. Other points of access to HIV care include the Tijuana General Hospital for antenatal and complex comorbid HIV cases, and through a small Capacites-supported collaboration that delivers through telemedicine HIV care that has been operating out of the Zona Norte since 2013. In 2006, Brower and colleagues provided population-based HIV prevalence estimates for Tijuana, demonstrating that MSM, persons who inject drugs, and those engaged in sex work were disproportionately burdened by the local HIV epidemic, reflecting an estimated HIV prevalence of up to 19, 6.5, and 4.8% respectively, compared to an HIV prevalence well below 1% in the general population. Following the implementation of Mexico's universal HIV treatment policies, we pooled the available epidemiologic data from 5 community-based studies in Tijuana that were conducted between 2004 and 2014. 1 was with MSM, 2 were with persons who inject drugs, and 2 were focused on females engaged in sex work, 1 of which specifically focused on female sex workers who also injected drugs. This yielded a total sample of 2,770 participants, 173 of whom were HIV positive, reflecting a combined HIV prevalence of just over 6% in these key populations. Among those who were HIV positive, we then examined their self-reported HIV test and treat experiences to identify the proportion retained across the care continuum. It is important to recognize that these data rely on a cross-sectional self-report and only capture a snapshot of a dynamic behavioral process. And because we could not confirm these data with medical chart abstractions, there is the possibility that we may overrepresent people who know their status, that are actually engaged in care as poorly engaged. But at the same time, the study methods are also of a great benefit, affording direct access to hard-to-reach key populations and allowing us to capture persons who had never engaged in HIV clinical care, an opportunity that is lost when data are restricted to medical chart abstractions alone. Now, by applying the 90-90-90 framework to this pooled HIV-positive sample, in order to achieve 73% viral suppression, we would need to observe 156 participants who knew their HIV-positive status at study entry, 140 who reported being on ART, and 126 who reported being virally suppressed. So just how off this 90-90-90 target are we based on the available data? Well, the quick answer is we are substantially off target. Only 14 participants reported knowing their HIV-positive status at time of study enrollment, 2 of whom were on ART, 1 of whom said he was virally suppressed. Looking at these estimates, a poor engagement in care played out for men who have sex with men, men and women who inject drugs, and females who engage in sex work, regardless of their injection drug use status. We see that in the pooled sample, 45% of those who are HIV positive said that they had ever previously tested for HIV, though only 8% reported knowing that they were HIV positive at time of study enrollment. Overall, HIV testing efforts had engaged more MSM than other key populations, though MSM were no more likely to know their HIV positive status. Among persons who inject drugs, women were more likely to report having ever had a lifetime history of testing for HIV, but were less likely to actually know they were HIV positive compared to men. And among women engaged in sex work, there were no significant differences in HIV testing history observed by injection drug use status, though in comparison, only women who engaged in both sex work and injection drug use knew they were HIV positive. While almost everyone who knew they were HIV positive had linked to care post-diagnosis at some point, less than 1% were on ART and reported being virally suppressed. Though we're unable to assess any statistical differences, of those that we observed who had linked to care, who knew their status, only MSM were observed to have accessed ART. So informed by these community-based data gathered from difficult to engage key populations, just how much would the city of Tijuana need to amplify their HIV test and treat efforts to reach the UNAIDS 90-90-90 goal in the next 5 years? So extrapolating from our current sample, city-driven efforts to ensure saturation of repeat HIV testing among key populations would need to identify 82% of those who would have remained previously undiagnosed in the absence of our surveillance studies. Of those diagnosed through increased repeat testing, an additional 80% would need to be linked to care and either immediately initiated on ARVs per the WHO guidelines, or at the very least retained in care until clinically eligible. Once initiated on ARVs, an additional 72% would need to become virally suppressed to reach the UNAIDS goal of 73% community-level viral protection among Tijuana's key population. There's no question that reaching the 90-90 informed targets in the next 5 years represent an exceptional challenge, calling for a rather intensive structural behavioral prescription to provide universal HIV testing and immediate ARV initiation when possible. Specific to Tijuana, building on current HIV prevention efforts, the government-funded HIV care structure would need to invest in ways to decentralize their current care models, making HIV treatment more accessible to key populations in the Zona Norte, and leverage policy changes to allow for routine testing and treatment monitoring of community members for these key populations, such as data to care models we might observe here in the US. Limiting the impact of stigma and discrimination as a deterrent to HIV testing and treatment behaviors could be supported by housing these services within the same community environments key populations not only negotiate HIV risk, but navigate their daily lives, and by delivering HIV testing, ART initiation, and adherence support through peers who share similar lived experience and shared sociocultural understanding. For example, reinstituting the use of the Previn-Mobile, or mobile HIV prevention RV units, once supported by the Global Fund, to deliver combination HIV prevention to key populations as a whole, regardless of sero status, staffing them with a trained HIV care specialist and peers to support annual HIV testing, acquisition of biannual labs for viral load monitoring, as well as monthly ARV pickup and on-site HIV risk reduction and ARV adherence support. for MSM, injection drug using communities, and sex exchange communities would seem to not only reduce structural barriers, but also maximize the resources and reach of community-level prevention efforts. The data further suggests that HIV-positive women who engage in sex work and/or inject drugs appear to face additional challenges learning their HIV status and engaging in treatment. For example, gender-responsive test and treat efforts may benefit from female-supported safe space, where female injectors can access routine testing, ARVs, and related support in the absence of having to disclose to male partners. Also, pro-HIV treatment policy changes are needed to benefit women engaged in sex work, tying work permits not to one's HIV-negative status, but to one's routine HIV testing and continued viral suppression and sexual health monitoring. So despite these exceptional financial, political, and resource challenges, the data clearly indicate that anything less will cost more from our collective society in the long run. And in reflecting on this last point, I would like to thank CFAR for the opportunity to engage in this dialogue with you here today, and to the participant staff and funders who not only made this work possible, but remain absolutely necessary for carrying this work forward in any meaningful way.
Nice work. I just want to say, I don't think your numbers are as bad as you present them. In that, of the people on ART suppression, who are on ART or suppressed, you're at 50%, not less than 1%. It's 90% of the previous. So you're at very, very low, then 14%, and then 50%. So it's just a matter of perspective. So
Okay.
it's maybe not as dire as it looks. You just need more diagnosis.
Yes, definitely more diagnosis.